because I feel very nostalgic. This I could not even think ever that again I will be able to come in this dais to take class. So I am very obliged to Maitri for arranging this class. You know that ascending tracts are also known as sensory tracts or afferent tracts. Ascending tracts are known as sensory tracts or afferent tracts. Ascending tracts or afferent tracts are the component of what is called, that is, afferent or sensory pathway. Afferent or sensory pathway. Ascending tracts are known as sensory tracts, which are the components of sensory or afferent pathways. Question is, what it is composed of? Afferent pathway. Afferent pathway. It is composed of 1, 2, 3. Number 1, that is receptors. Receptors or peripheral end organs. Receptors or peripheral end organs are basically of two types: exteroceptive and proprioceptive. Apart from these receptors, next is that at least three chain of neurons. Three chain of neurons. At least three chain of neurons, which are known as first order neuron, second order neuron, third order neuron. After the three chain of the neurons, that is the center. Center for perception. Center for perception. So if we see three chain of neurons, which I told, first order neuron, second order neuron, third order neuron. With one exception, this first order neuron of afferent or sensory pathway is always situated outside the central nervous system. Exception is in relation to the brainstem, that is where it is in case of mesencephalic nucleus of trigeminal nerve. Apart from this, first order of neuron always lying outside the central nervous system. And as it is lying outside the central nervous system, this first order of neuron is nothing but, that is, dorsal root ganglia cells, which are also known as posterior root ganglia cells, which are situated very close to the spinal cord. I am a corresponding sensory ganglia of sensory component of cranial nerves above the first cervical nerve. So first order of neuron lying there, and as you see that this is the first order of neuron and which enters the spinal cord. This is entering in the spinal cord. As it enters the spinal cord, therefore, from here second order of neuron starts. And the second order of neuron that starts here, it ascends up. So second order of neuron lies in the spinal cord. Second order of neuron, obviously as it is a sensory neuron, it will be lying in the dorsal gray horn, any lamina of dorsal gray horn of the spinal cord. While from the second order neuron, as it ascends high up, and as it ascends high up above the level of the spinal cord, and as it extends into the above the level of the spinal cord, this center is known as supraspinal center, supraspinal centers, or subcortical centers. Supraspinal centers. As above the level lies the cortex, so it is also known as subcortical centers. Second order of neuron relays into the next order of neuron, which lies in the supraspinal center or subcortical center. What are these supraspinal centers or subcortical centers? It includes three categories of centers. These three categories of centers are known as, one is that is known as a thalamus. Number two is the cerebellum. Number three, non-cranial nerve brainstem nuclei. I utter the non-cranial nerve brainstem nuclei means these are not the nuclei of cranial nerves, but other than this cranial nerve nuclei in the brainstem, in which most important is reticular nucleus and also various mesencephalic non-cranial nerve nucleus. For example, center of the tectum, for example, red nucleus, for example, olivary nucleus. So this is second order of neuron, terminates or relay in the supraspinal centers, and while from the last order of neuron, that is third order of neuron, which lies in this center, which goes to sensory area of cerebral cortex. So these are three orders of neurons, which is a must for the afferent pathway. Next question is, what is meant by these ascending tracts in relation to these three order of neurons? You see therefore that this is the axon of second order of neuron. This is axon of second order of neuron, which mostly, I utter the word mostly, lies in the spinal cord. Why I use the word mostly? Exception will be clarified subsequently. So the second order, the axon of the second order neuron, which mostly lies in the spinal cord, and this is forming the ascending tracts or afferent tracts. So this is ascending tracts. With this, next we pass on to the classification of afferent tracts. Classification of afferent tracts. As we come to know that the supraspinal center, I told already, that is, which are of three categories. One is thalamus, one is cerebellum, another is non-cranial brainstem nuclei. Therefore, classification of ascending tracts says that it is of three types, 1, 2, 3, that is to thalamus. To thalamus for sensory perception, for perception of sensation. To thalamus for perception of sensation. Number two, we are talking about the classification of afferent tracts which are classified into three categories. To thalamus for perception of sensation. Next to cerebellum. Ascending tracts going to the cerebellum. One important point to note. These are obviously not for perception, which has been already categorized. So ascending tracts going to the cerebellum, which is for muscular coordination, coordination of muscle movements in reference to or for the postural adjustment of the body. So this is to cerebellum for muscle coordination. This is for muscle coordination. Next, to brainstem nuclei. Brainstem nuclei. To brainstem nuclei, these are concerned with some reflex activity. So this is for reflex activity. This is for reflex activity. When we utter the word reflex action, we think of, first comes in our mind about the spinal cord. You know that in case of spinal cord, in each and every segment, there is an arc or circle, circuit, which is known as reflex arc. That reflex arc is a horizontal reflex arc in a particular segmental level. But parallelly, in central nervous system, there are also some vertical reflex arcs. So in case of vertical reflex arc, this ascending tracts to the brainstem, which ascends to the brainstem nuclei, and these are concerned with the various reflex activity or modulation of the reflex activity, moderation of the reflex activity. In some cases, in the brain there lies horizontal reflex arc, as for example, you know that pupillary light reflex, accommodation reflex. Similarly, there is a reflex arc which is known as spino-visual reflex. If we consider the spino-visual reflex, in case of spino-visual reflex, where there lies also moderation is caused by these ascending tracts. For example, the spinotectal tracts. So these are classification of ascending tracts. First, if we go to first ascending tracts going to the thalamus. Again, this ascending tract going to the thalamus, ascending tract going to thalamus, it is divided into two types. There are two kinds of ascending tracts. One is known as dorsal column tract. Dorsal column tract. Second is known as anterolateral tract. Second is known as anterolateral tract. First, dorsal column tract. As the name implies, dorsal column tracts are the ascending tracts which ascends through the dorsal white column of spinal cord. And this dorsal white column tract or dorsal column tract, which has got two important characteristics. Ascending tracts ascending through the dorsal column or posterior white column, two basic important characteristics. Number one is that this dorsal column tract, which passes through the dorsal column, which is having its only sole area in the dorsal column, with exception in the cervical region of spinal cord. If we see about the cervical, take away the cervical with the exception of cervical region of spinal cord. Why I tell this, it will be clarified later. Dorsal column tract, it was fully occupied whole of the dorsal column. Means therefore, no intermingling with, number one, with any other sensory tract, no intermingling with what? Descending or motor tract. Number one characteristic. Number two characteristic is that, as you see that from this diagram, this is what? Posterior root ganglia cells is here. Therefore, this is the afferent nerve, sensory component of spinal nerve, and which enters here. And you see that this is posterior root ganglia cell has got a peripheral process equivalent to the dendrite of neuron, central process which is usually shorter and which is supposed to relay in the second order neuron in the posterior gray horn of the spinal cord. But dorsal column tract, you see therefore, this is posterior root ganglia cells having the central processes, main bundle of central process which is entering into the apex of the dorsal horn. But there are number of filaments which are medially directed, as you see with that green color. These are filaments which directly enters into the posterior white column. So, second characteristic feature of this dorsal column tract is that dorsal column tract is nothing but this is formed by central process or axonal process of first order of neuron which are lying in the dorsal root ganglia. Two characteristics. After the sensations carried. What are the sensations carried by the dorsal column? Sensations carried. Sensation carried. Number one, exteroceptive. Number two, proprioceptive. These two are somatic sensation plus visceral sensation. Three kinds of sensations are carried. Exteroceptive. Before we go to the proprioceptive, exteroceptive. Light touch. Light touch sensation. Light touch, also known as fine touch. Also known as, it is also including the one kind of special touch sensation that is known as discriminative touch. So if we, on the tip of the finger pad, if we touch 2 points with a distance of 3 millimeter apart, this sensation for the 2-point touch is carried by this tract, dorsal column tract, which is known as 2-point discrimination. Light touch, fine touch, as well as discriminative touch. Number two, apart from this exteroceptive sensation, that is number 2 and 3, conscious proprioception. Conscious proprioception. Conscious proprioception. What is that? Suppose When we walk, we lift our leg, then we take the steps. Or in other words, in this case, we are aware that how much we have lifted our limb off the ground. Then it will strike smoothly against the ground. And this conscious proprioception means that this is sense of position and movements of muscle and joints. Suppose if we just dorsiflex great toe, we are aware passively. If we do great toe is dorsiflexed, we are aware of this, that the toe is dorsiflexed. Again, if it is plantarflexed, we are aware of this. So this is sense in relation to the conscious proprioception. So suppose if our hand is outstretched and if we are asked to shut our eyes, close our eyes, then if we are asked to touch the tip of the nose, it is possible because we are having the sense of position of our abducted upper limb. So we are aware that how much we have to move this to touch the tip of the nose. So this is sense of position of muscles and joints, conscious proprioception. Vibration sense. Vibration sense. Vibration sense. If any vibratory movements is felt on the surface of the body, particularly bony prominence, and that is called vibration sense. So exteroceptive, proprioceptive and autonomic, visceral. Number 4 is this. So awareness for fullness of urinary bladder and lower lung gut. Awareness for fullness for urinary bladder and lung gut, and which is also carried through the dorsal column. So that is sensations carried. After this, we'll see that entry in the spinal cord. Only one important point to tell. Entry in the spinal cord is that it enters the spinal cord by multiple finer medial filaments of central axonal process of dorsal root ganglia cells, which are still the part and parcel of the first order of neuron. This, when it enters, after entry, then what it does? Ascent. It ascends. So this, after this, it reaches the posterior column, and as it reaches the posterior column, it ascends here and ascends to the posterior column, which is also known as posterior funiculus. And this 5 sensations carried from the lower half of the body. This is below the line, lower half of body. This is lower half of the body. This is upper half of the body. Upper half of the body. Sensation carried from the lower half of the body as it ascends to the upper segments of the spinal cord, it is superadded laterally by the fibers entering from the upper half of the body. So this is a signal tract, but as it ascends, it shows a specific arrangement of fasciculi. So suppose sacral region added next by the lumbar region fibers, fasciculus. Next it is added by thoracic region, finally the cervical region. So these fasciculi, stratifications or laminations of the fibers in the upper level are basically divided into two components, one medially placed and one laterally placed. And these are medially placed, which are from the lower half of the body, laterally placed, which are from the upper half of the body, both of them divided into medial tract and lateral tract, which ascends. Above the spinal cord, each reaches the brainstem. You know that I told that second order of neuron usually mostly lies in the spinal cord, while it is the exception. Third order of neuron lies where? Either in the thalamus or where? Cerebellum or brainstem nuclei. So before the cortex, that is the next order of neuron. So still there is a need of relay in the second order of neuron. That is why just above the spinal cord, at the lower end of the medulla, this is the section through the medulla. At the lower end of the medulla, it will have to relay before it goes to the next order of neuron. So the second order of neuron, which are lying medially and laterally, you know that this is gracile nucleus, this is cuneate nucleus, this is cuneate nucleus. So they will relay in the second order neuron, gracile nucleus and cuneate nucleus. That is why they are named as gracile tract, and that is why lateral one is known as cuneate tract. I told that it is that ascending tract of dorsal column where these two tracts are having the concrete bundle placement. So that is why they are also known as fasciculus. Fasciculus gracilis and fasciculus cuneatus. Gracile tract, fasciculus gracilis, cuneate tract, fasciculus cuneatus. Relay in the second order neuron. After that, very briefly, we will pass on to the next what happens. After relay in the second order of neuron, axon of the second order of neuron, and which will have to decassette. As they decassette in the medullary level. So the decassette means intercrossing of right to left side, so interlacement. So after decassation, then the axonal fibers of this nucleus gracilis and cuneatus, and which will ascend as a continuation of this dorsal column tract, and in the form of compact bundle, very concrete compact bundle in the central core of brainstem, which is known as lemniscus. This lemniscus, among the many other lemnisci, 4 are there in number, is most medially placed. So that is why this is known as medial lemniscus. So which is known as medial lemniscus. And this medial lemniscus ascends through the central core of the brainstem to relay ultimately to the next order of neuron, that is third order, which is nothing but, that is thalamus, thalamic nuclei, wherefrom finally axon of third order of neuron will go to the center, third component of the afferent pathway, that is centered means sensory area of cerebral cortex. Clinical importance of this tract. Important point to note is that there is a disease which is known as tabes dorsalis. Tabes dorsalis. When there occurs, it is a condition in tertiary neurosyphilitic condition, where there is selective degeneration of dorsal white column. Selective degeneration of dorsal white column along with the posterior root ganglia cells. These will obviously give rise to selective loss of function of dorsal column tract. What will happen? Many things will happen. Loss of what? Exteroceptive sensation, light touch. Light touch can be tested by simple stroking of the skin surface with the help of the finger. Simple stroking of the skin surface with the tip of the fingers, that is light touch. Discriminative touch on the finger pad, on the finger tip of the finger pad. If we touch 2 points, discriminative touch can be assessed. Apart from this, vibration sense. Usually vibration sense, you know that, which is tested with the help of the tuning fork, vibrating tuning fork, applied to any bony surface, either lateral malleolus, or fibula, or frontal bone in the forehead, in this region, vibration sense. But most important is that is loss of conscious proprioception. And you know that along with this there is a sensation which is carried by this tract, which is known as stereognosis. Stereognosis is an ability of an individual by which one person can identify or recognize any object by handling it, just handling, to identify the size and shape of this object. That is known as stereognosis. But most important is that conscious proprioception. And this conscious proprioception and is clinically tested by, as I told earlier, that is finger nose test or heel knees test, or in case of what, if we ask the patient just to stand erect and close the eyes, stand erect and close the eyes, the person will have a tendency to fall, because the person is not having the aware of this position of the body. Over and above, there is a condition which is known as clinical sign, which is known as the Romberg sign. Romberg sign positive. Romberg sign positive. What is that? That is, apart from this tendency to sway or fall while walking with the eyes closed, just if a person is asked to walk, when the limb is lifted off the ground, we are aware of that how much it is lifted, we smoothly just touch the ground. But the patient, in case of the eyes closed, and the patient will have the stamping gait. So the foot will strike only against the ground, and that gives rise to the typical gait or style of walking that is known as stamping gait. This is known as stamping gait. Okay. So this is Romberg sign positive is an example clinically is a sensory ataxia. This is the sign of sensory ataxia. This sensory ataxia also occurs in some other disease, in vestibular disease and also in case of cerebellar disease. But difference with this is that in case of vestibular disease and cerebellar disease, whether the eyes are closed or open, it is immaterial. But in that case, this is if eyes are closed, the Romberg sign will be positive, giving rise to a feature of sensory ataxia. Tract to the thalamus. Next is anterolateral tract. Anterolateral tract, if you see that, for that quickly we'll go to the sketch. ventral nerve root, dorsal nerve root. On the surface of spinal cord, you know that pia mater, where it wraps. We show in one side, as it wraps on the lateral side of spinal cord, the pia mater gives the serrated projections are known as denticulate ligament. Denticulate ligament. Denticulate ligament is anterolateral tract. Denticulate ligament is the posterior line of demarcation of the extension of anterolateral sensory tract. So if it is that the sensory tract, which is roughly positioned like this, We see therefore this is dorsal root ganglia with the dorsal nerve root. Anterolateral tract is lying in front of denticulate ligament and which extends from the lateral white column also into the anterior white column. This anterolateral tract, destined to the thalamus, what are the sensations carried? Sensations carried. Sensations are pain, nociception, temperature, touch, which is the touch that is coarse touch, coarse or crude touch, pressure sensation, plus sense of itch, sense of tickle, plus sense of sexual orgasm. Sensations carried: pain, temperature, coarse touch, pressure, itch, tickle, sexual orgasm. The fibers of this tract, when ascend to the anterolateral column, these fibers are basically of two types. One important types basic are which are the non-myelated fibers. Non-myelated fibers carries the different sensations but very thinly, finely myelated fibers which carries, that is, pain, temperature sensations. So two different kind of fibers which are ascending to this anterolateral tract. Next is entry into the spinal cord. When it enters into the spinal cord, it will enter directly into the dorsal root, main limb of the dorsal nerve root, central process of dorsal nerve root, and which will enter the posterior grey horn. Earlier, it was thought that this is pain and temperature fibers which are relying only into the lamina 2 and lamina 3 of Rexed lamination, but it is told nowadays that these fibers which are entering into all the lamina of the dorsal grey horn, starting from lamina 2 to lamina 7. Lamina 2 to lamina 7. So first is entry. Entry in the spinal cord. When this fiber enters, what happens? These fibers, first they will ascend or descend. Reaching into the spinal cord, they will either ascend for 1 or 2 segments or descend for 1 or 2 segments before they relay into the second order of neuron. And at the apex of the dorsal grave horn, this ascending and descending fed in a series, this is forming a tract which is known as dorsolateral tract of Leisure, which is known as dorsolateral tract of Leisure. Dorsolateral tract of Leisure. A-U-E-R. S-S-A-U-E-R. Dorsolateral tract of Leisure. After entry, they are relayed. When they relay, the fibers which are of 2 different kinds, one, these fibers which will relay mainly into the lamina 2 to lamina 5, and when they will relay, next order of neuron will start from here. As the next order of neuron will start from here, it will cross the midline and it will ascend. They will pass to the other side. So these fibers are pain and temperature fiber. Pain and temperature fiber. As they ascend, they will ascend up. Similarly, touch and pressure fiber, touch and pressure, they will enter, and as they will enter, they will also cross, and it will come also to cause opposite side, coming to this anterior funiculus to form respectively, that is specially named as lateral spinothalamic, and this is anterior spinothalamic tract. Lateral spinothalamic, anterior spinothalamic tract. Question is, there is slight line of demarcation. The fibers are partly intermingled, and as it was, therefore, these fibers show some stratification. Stratification or lamination of the fibers of lateral spinothalamic and ventral spinothalamic tract for 2 different kinds of sensation. Number 1 is that when the fibers are entering the spinal cord from the lower level, so as they are entering from the lower level, they are added by the fiber of the upper level. So you see that in case of uncrossed tract, dorsal column tract, we have seen that lower fibers are placed more medially, upper fibers are placed more peripherally or laterally. But as you see, the simple thing that as it crosses the midline, therefore lower fiber will be pushed more laterally and it will be superadded by the upper level fibers medially. So one kind of lamination or stratification, if we see the stratification, stratification of one kind of stratification is that if this is whole anterolateral tract, 1, 2, 3 and 4. So 1, 2, 3 and 4, if this is considered as a midline, this is midline. Obviously this is the section of the tract of the right side, this is the front, this is the back. Therefore, this is sacral, second is lumbar, next is thoracic, next is cervical. So they are lateromedially stratified or laminated. Again, it is not truly, that is, lateral spinothalamic tract which carries the pain and temperature, and ventral spinothalamic tract carries the touch and pressure. If we see another kind of stratification of these two kind of sensory fibers, so if this is stratification of these fibers are like this. So this is pain and temperature, this is the midline, this is midline, so this is touch and pressure. Touch and pressure fibers are like this. After their destination, that is further course, this spinothalamic tract, which are therefore more they ascend high up, they will be divided into two columns, ventral and dorsal spinothalamic tract. Fibers of touch and pressure will be aggregated more ventrally, and fibers of this ventromedially, and fibers of, that is, pain and temperature, which are dorsolaterally. In the upper level, both this bundle of fibers, when they will enter the brain stem, they will have two different destinations. Two different destinations is that we have seen the position of the medial lemniscus. Medial lemniscus is most medially situated, that is why it is so called. Therefore, these fibers which are carrying the touch and pressure, they will be amalgamated with the fibers of medial lemniscus. But fibers carrying pain and temperature sensation, these fibers will have separate entity bundle, and the separate entity bundle in the brainstem core will ascend another lemniscus which is carried from the spinal cord, lying just lateral to the medial lemniscus, which is known as spinal lemniscus. So now, through the medial lemniscus, touch and pressure fiber, and through that spinal lemniscus directly, pain and temperature fibers, they will finally, above the brain stem, will relay into the nucleus, that is ventro-posterolateral nucleus of the thalamus. This anterolateral tract, that is lateral and medial spinothalamic tract, which, as I have shown, which is lying just anterior to this ligament denticulatum or denticulate ligament, just behind this tract, there lies the posterior part of the lateral white column. There lies the important motor tract, that is bulk of lateral corticospinal tract. So sometimes what happens, to relieve excruciating pain, particularly in case of the malignant disease, where pain is not possible to be relieved, through neurosurgery operation, this pain can be relieved by an operation which is known as, knife, which is directed in this direction, taking the guard of denticulate ligament, and that is known as anterolateral chordotomy, which is known as anterolateral chordotomy. Knife is passed on the anterolateral aspect of the spinal cord, taking the guide of the denticulate ligament to cut through this lateral spinothalamic tract, carrying pain and temperature sensation, just preserving the position of this lateral corticospinal tract, important descending tract or the motor tract. Thus this known as anterolateral chordotomy. Ligamentum denticulatum as a guide. There is a disease, if you see, that is central canal. We know that there lies, this is anterior grey and white commissure, there lies decussation of the fibers of spinothalamic tract, which includes lateral spinothalamic tract carrying pain and temperature sensation. And here is the position of anterior grey horn, where lies the lower motor neuron. Here is the position of the tract behind the denticulate ligament in the lateral funiculus or lateral white column. That is, we know that this is the position of lateral corticospinal tract. There is a disease which is because of the developmental reason, that is known as syringomyelia. Disease is known as syringomyelia. Syringomyelia is because of developmental reason. There it is a degenerative disease which causes excavation of neural tissue surrounding the central canal. Excavation of neural tissue. It is a disease causing excavation of neural tissue surrounding the central canal, leading to dilatation of the central canal with the loss of surrounding neural tissue, and which usually starts from, if you consider the central canal, which usually starts from, that is C8 T1 level, 8 cervical and first thoracic level. From this level, dilatation starts and it proceeds upwards and outwards. So above this, it can extend up to the C4, and below this, it can extend up to T4, T5. So dilatation starts from the C8 T1 and which extends up and down, leading to what initially, first, this is number 1, this is number 1, this is progress, number 2, after further process, this is number 3. Excavation leads first damage of the spinothalamic tract, and which obviously from this cervicothoracic region, typically it occurs in the cervicothoracic region, so it will give rise to the loss of sensation, which is known as that is anesthesia. Anesthesia is the level of the neck, upper limb and the chest, what is typically known as jacket type of anesthesia. Number 1. And this dilatation is maximum when C8T1. As it is maximum in the C8T1, this will give rise to the loss of what? Number 2, that is loss of function of lower motor neuron or anterior horn cells of the spinal cord at the level of 8 cervical and first thoracic, causing the disability, that is paralysis or loss of function. First starts with the loss of function of the small muscles of the hand, which are innervated by the C8T1 segments. Further, if it expands further, it may lead to the damage of this corticospinal tract So obviously it will cause spastic type of paralysis if it is usually bilateral. So this tract to the thalamus, tract to the cerebellum. তোমার কতক্ষণ সময় আছে? চারটে? আমাকে বলে দেবে। Tract to the cerebellum. General plan. Tract to the cerebellum are in general named as spinocerebellar tract. The spinocerebellar tract are the tract to the cerebellum, but it does not mean the tract of the spinocerebellar tract are all about the tract to the cerebellum. I think I am clear to you. Spinocerebellar tract are the tract to the cerebellum, but it does not mean that spinocerebellar tract are not only the tract to the cerebellum. So there is something else which will be clear. So if you see that, very quickly, we see that outline. Spinocerebellar tract, sensation carried. These tract departs from the tract to this. Initially at the beginning I told that departs from the tract to the thalamus by the fact that these are the afferent tract or sensory tract which are concerned with the postural adjustment of the body through coordination of the muscle movement. Therefore, these tracts which are ascending to the cerebellum, it is not for perception, but these impressions, that is inputs, are received by the cerebellum, and these are known as, that is, inferior afferents or ascending afferents, in addition to the horizontal afferents which are horizontally entering in the cerebellum from the vestibular nuclei. Along with this, descending afferents from the cerebral cortex via the pathway, cortico-pontocerebellar pathway. So these tracts to the cerebellum is one of these three different afferent fibers to the cerebellum, which are not for perception, but these are for received by the cerebellum, where these inputs are received, they are analyzed, they are after analysis, they are coordinated, and then direction is given, directive is, command is given by the efferent fibers from the cerebellum to the cortex for the muscle movements. So this is a component of all these three different afferents, that is ascending afferents from spinal cord, horizontal afferents from vestibular nucleus, vestibulocerebellar fibers, descending afferents, cortico-pontocerebellar fibers. All these three are received by the cerebellum for muscular coordination. These are, therefore, we usually know, therefore, these are carried from the proprioceptors, means that is deep-seated end organs. So sensations carried. Where from they are carried? Deep-seated end organ in the muscle, known as muscle spindle, end organ in the tendon, Golgi tendon organ. But in addition to that, these deep-seated informations are carried from these also carried from cutaneous receptors. That is touch and pressure receptors beneath the skin, where from the sensation are carried also by this spinocerebellar tract. As they are carried from these different end organs, proprioceptors as well as exteroceptors. Exteroceptors, that is touch and pressure cutaneous sensations. So these fibers, which will just pass the first order neuron, that is the dorsal root of the spinal nerves. So cell bodies are obviously, as usual, the dorsal root ganglia cells. Then what happens? And then they will enter into the spinal cord to relay the second order of neuron in the spinal cord. When they will enter to relay in the second order of neuron of the spinal cord, and this some fibers will relay into the medial part, medial half of lamina 7 of posterior gray horn cells. And medial part of lamina 7 of posterior gray horn, which is known as thoracic nucleus, or Clark's column of cells. Clark's column of cell. Clark's column of cell. You know that this Clark's column of cell lies where? From 8 cervical to first thoracic, first 8 cervical, first thoracic to first or second lumbar. So C8, T1 to L1, L2 maximum segments. Therefore, these fibers carries the sensation from which level? From, that is mainly the thoracic level and upper lumbar level. Means therefore, it is from the, that is middle part of the body, middle third of the body. These sensations, as they are carried, they are relaying into the nucleus here, that is medial half of lamina 7, thoracic nucleus, or Clark's column of cell. After this, these fibers will form the bundle of tract. Axon of these cells, this will form the bundle of tract, and it will reach same-sided lateral white column along its a narrow strip in the posterior half. So posterior half of peripheral part of lateral white column, and where they will aggregate and will ascend up. And this is therefore forming what is known as dorsal spinocerebellar tract. Dorsal spinocerebellar tract. Think of the sensations carried below this L1, L2 level. Same kind of sensation. Because these kind of sensation, that is proprioceptive sensation from muscle spindle, Golgi tendon organ, and also the cutaneous receptors, are carried from all the level of the body. But Clark's column of cell at best extends lower down up to the L1, L2. So what happens to below the level of L1, L2? Same kind of sensation from same kind of receptors are carried by the dorsal nerve root, and these fibers will just come from opposite side. And as they come from opposite side, they will not find lamina 7. They will, instead of lamina 7, which is having the lower limit L2, therefore this is below L2. That means lower lumbar and sacral region, where from the fibers will enter and relay into the lamina 5. This will enter in the lamina 5, and where from, that is next order of neuron will start, and it will cross. As it is crossing, and it will go to the opposite side to the grey and white commissure, and it is, as it is passing from here, it is crossing to this commissure in front of the dorsal spinocerebellar tract, peripheral narrow strip, the anterior part of the lateral white column, while from the fiber will ascend as what is known as, obviously, ventral spinocerebellar tract. Ventral spinocerebellar tract. Ventral spinocerebellar tract. Difference therefore lies here. Dorsal, ventral, having difference in the level, similarity, same kind of sensation, similarity, same kind of receptor, but difference is that dorsal, ventral, the first difference is that one is entering into the lamina 7 class column, one is entering, relaying into the lamina 5, therefore which does not find the lamina 7 typical class column of cell. So this is from the lower half of the body. This dorsal and ventral spinocerebellar tract, when it ascends, we know that it is having, both of them are having some other differences. Already this ipsilateral tract is the cerebellum, dorsal spinocerebellar tract, and we know that basic conception is that the cerebellum is always having the ipsilateral control on the body. Therefore, dorsal spinocerebellar tract which ascends from along the same side, and these will ascend up to the medulla. From the level of the medulla, this will do what? Through the inferior cerebellar peduncle, the bridge between the medulla and the cerebellum, it will pass on to the cerebellum. Difference of ventral spinocerebellar tract, which has already been crossed but needs to be uncrossed to be ipsilateral in the cerebellum, needs to cross another time. For that, it will have to ascend further up, and beyond the pons it will reach up to the midbrain. Reaching the midbrain, again for the second time it will cross in the central core of the midbrain, and then from the midbrain through the bridge of midbrain with the cerebellum, which is the superior cerebellar peduncle, it will go to the finally the cerebellar hemisphere of sensite. So that is the two differences. Last, I told one word, that is dorsal and ventral spinocerebellar tract are the tract to the cerebellum, but these two tracts are not all the tracts to the cerebellum, means there is some other ascending tracts from the level of the spinal cord to go to the cerebellum. What will be that? You think of, as you have thought about the sensation carried below the second lumbar, you have to think the sensation to be carried above the C8 at first thoracic level. So above the first thoracic level means from the sensations from the upper limb, mainly sensations from the upper limb and the cervical region. This same kind of sensation needs to be carried, but these fibers will enter the cerebellum, enter the spinal cord, not through the main dorsal nerve root. It will pass through the same medial filaments which goes to enter into the dorsal column. So fibers carrying the same kind of sensation corresponding to the spinocerebellar tract fibers above the first thoracic, they enter to the medial filament, medial branchlets of central process of dorsal nerve root. It will enter obviously where? It will enter directly into the dorsal column. So, does not find any second order of neuron in the spinal cord, but it will have to relay in the second order of neuron below the cerebellum. So, this fiber will ascend
I told at the beginning, the dorsal column tract is unique because it is the monopoly place is for the dorsal white column. With some exception, this is the exception. These fibers are also passing with the dorsal column tract, and it will ascend up along with the dorsal column. Where it will go? It will go above the spinal cord in the medulla. It will go in the medulla. If we see the medulla from behind, it is something like this. It is something like this. Means therefore, that is what dorsal median sulcus, tubercle, gracile tubercle, cuneate tubercle, then ICP, inferior cerebellar peduncle. This is inferior cerebellar peduncle, and here is the cerebellar hemisphere. Here is the cerebellar hemisphere. This is the cerebellar hemisphere. So you see that we are looking medulla from behind. As we are looking medulla from behind, we see therefore this is what? This is posterior nerve root from behind. Posterior nerve root from behind. Posterior nerve root from behind. This is the spinal cord, cervical region. This central process of posterior nerve root will ascend. It will ascend up. Dorsal column, further up. Posterior part of this, back of this medulla. This is the cuneate nucleus. Lateral to the cuneate nucleus, there is a small elevation known as accessory cuneate nucleus or lateral cuneate nucleus. Mid cuneate nucleus is medial, inferomedial, so this is superolateral. So these fibers will go to rely in these cells. So these fibers will go to this nucleus, which is known as accessory or lateral cuneate nucleus. Accessory or lateral cuneate nucleus. From where axon of this neuron will pass as what is known as posterior external arcuate fibers. As posterior external arcuate fibers, they will reach to the cerebellum. So this tract can be named as spino, in between, cuneo. Spino cuneo cerebellar tract. This is known as spino cuneo cerebellar tract, where that is sensation carried similar to this dorsal and ventral spinocerebellar tract above the level of 8th cervical or fasciculus. Last is that is ascending tract to, a few words I will tell, ascending tract to the brainstem nucleus. Ascending tract to the brainstem nucleus, or for what? Ascending tract to the thalamus, I told in the beginning, for perception of sensation. Ascending tract to the cerebellum for muscular coordination towards postural adjustment of the body. Ascending tracts to the different nuclei of brainstem other than cranial nucleus for some reflex action. Reflex action means either they are directly concerned with the reflex arc, formation of reflex arc, or they are for modulation of the reflex activities. Most important is that is spino-reticular tract. Spino-reticular. Most important is spino-reticular tract. Extends over the whole length of the spinal cord. This extends over the whole length of the spinal cord. Spino-reticular tract. What is that? This is carried from the peripheral end organs, and which are, one thing is that for perception of deep-seated pain. For perception of deep-seated pain, suppose if we press over the tendon Achilles firmly, we feel the sensation, that pain sensation or pressure sensations. And this is by the sensation carried by these muscular tendinous end organs, either muscle spindle or Golgi tendon organs. So deep-seated pain is felt by the spino-reticular tract, number one. Number two, that it goes to the brainstem reticular formation, wherefrom there lies the descending tracts, reticulospinal tract, and this reticulospinal tract, and which will descend and project into the anterior horn cells, alpha and gamma neuron of spinal cord. Therefore, it will give rise to the moderation or modulation of the sensation. So this is concerned with what? That is reflex arc, number one, perception of deep-seated pain, number two, that is modulation of the pain sensation. How is that? That is as it occurs in the local level, that is particularly in the spinal cord segmental level. Suppose when there is a pain perceived in a particular area, what we do? We do rubbing. These mechanoreceptors which carries impulse and which inhibit the activity of the neurons, sensory neurons, which carries pain and temperature sensations. Similarly, what happens? Suppose in limbic system, by the descending fibers projecting on this reticular formation, it will give rise to some inhibitory effect, and for which sometimes in some cases, due to some emotional condition of the body, emotional status of the body, where pain is less felt. And this is the role of this spino-reticular tract. One is a deep-seated pain sensation perception. Number two is that mind means what? You can have the question, if we go to the reticular nucleus, where is the perception? Know that it is total tract in that case. Deep-seated pain sensation perception is spino-reticulo-thalamocortical tract. That is the direct sensory tract. Apart from this, there lies what? Modulation from the reticular formation by the reticulospinal tract into the lower motor neuron. And therefore, said that there is some reflex activity when there is deep-seated pain is felt, motor reflex activity. This is spino-reticular tract. Another important ascending tract related to the reflex function is that spinotectal tract. Spinotectal. I told that these tracts, either they are concerned with what? Either they are concerned with the formation of the reflex arc, like the segmental spinal reflex arc, which is horizontal, it is the vertical reflex arc, or it is for what? It is for some action over the horizontal reflex arc. As what it is that?